Hello, friends. Very good evening to all of you. So, I welcome everyone to this very interesting and a very useful webinar where we will be talking about lung nodules. And in the Indian context, how do we go about approaching a case of a lung nodule? That will be the focus of today's webinar. So, before we go on to the webinar per se, there are a couple of things which I want to say. First, I would like to thank CCI, especially the founder of CCI, Dr. N.H. Krishnanna, who has conceptualized this and made all this possible. And this topic, why is this relevant to us today more than at any time in the past? Hmm? So all the panelists here would agree with me, and I'm sure all of you are listening to this webinar also would agree with me that lung nodules as a whole we are picking up more often. This is mainly because of the increased utilization of the CT scans. So the acceptance to CT scans, the number of centers where CT scans are being performed and the number of scans being ordered is exponentially on the rise. So the more CT scans we do, the more nodules we pick up. And the more nodules we pick up, the more accurate we have to be. So all of us have to understand the algorithm to approaching a case of a nodule which we picked up on an X-ray or on a CT scan. Second is also the fact that tomorrow, August 1st, is the World Lung Cancer Day. And today we are talking about lung nodules and how to get a correct diagnosis. And lung nodules, as we all know, is the earliest radiological manifestation of lung cancer most times. Not only lung cancer, I would say many lung diseases, infectious and non-infectious, present as lung nodules in the initial stages. So when we are able to diagnose nodule correctly, we'll be picking up these diseases at an early stage. And then if you pick up early, you treat them better. This is the second reason why we have to understand the approach to a lung nodule. So again, coming back to the people who are behind this webinar, this series of webinars. So I don't think it is fair on my part to start this webinar before mentioning the fact that this is the sixth consecutive year. I think 5 years have finished. 2020 March was the first CCI webinar, and now we are 5.5 years down. And with a pinpoint precision and consistency, these have been going every week. And now we are almost reaching the 300th webinar. So behind this team effort, there are a lot of people. So we have our CCI President, Dr. Ashish, Dr. Anil Maske, the CCI Secretary, Dr. Narayana Pradeepa, my dear friend, Dr. Vijay, who's also there, Dr. Atri Bhai, Dr. Ravi Bhai, Dr. Shivani Madam, and Dr. Kira. So all of them have been working, making sure that all the webinars happen meticulously. And along with me today, we have five panelists. All of them are my very dear friends, and all of them are experts in their field. So today we have in our panel, I'll be sharing my screen, and as I share my screen, I will also introduce the panel. So I'll also tell the flow of events in the next 1.5 hours. So when I start, I will give a very brief introduction about lung nodules that would probably take maybe around 10 minutes or 15 minutes, not more than that. And then we will discuss five cases. So five real life cases. And then this is where the panel will interact, and then we will try to give several take home messages for the audience as to how we go about managing a lung nodule. And we will also have audience questions. I will request all of you, all the people who are logged in today, to please feel free to post as many questions as you can, because only then we will be able to have a more lively and practical discussion. So we will be able to see your questions. We will try to address as many as possible. So today with me in the panel, we have five panelists, as I have said. So we have Dr. Loveleen, Dr. Samir, Dr. Vipul, Dr. Nikhil, and Dr. Shilpi Dosi. And today also is a multidisciplinary discussion. So we have three pulmonologists, one radiologist, and one pathologist. So once I finish my 10-minute talk, I will introduce the panel and then we will have the panel discussion. So very briefly about lung nodules, how we will approach them in 2025 as a pulmonologist. So we also have a radiologist, so we'll talk about that part also. So first is the definition. I think this is something which we will talk again, but the most important thing is that the size. Anything less than 3 centimeters rounded opacity will be a nodule. Anything more than 3 centimeters will be a mass. So it's usually well defined. It can be ill defined. So broadly, solid, subsolid, ground glass. This also we will go about. You can also classify nodules as being solitary or multiple with one dominant. So solitary pulmonary nodule is one different entity altogether, and which is what we'll be focusing about. We'll not talk about multiple nodules in today's webinar. Now, nodulology as such has picked up a tremendous pace in India over the last 5 years, mainly because of the number of gadgets which we have. I think in intervention pulmonology, the most number of new gadgets which have been launched are in the field of peripheral bronchoscopy or nodulology. So we will talk about all of these, the radiolibus, the fluoro, cryo, thin bronchoscopes, and the newer ones like the CBCT, the navigation, the lung vision, so on and so forth, how we can utilize them. So whenever we have a nodule, this is what we follow. 10-step approach is what I would say, 10 steps. So I will take 30 seconds probably for each step. So the first step is to identify a lung nodule. So this will be done either on an X-ray or on a CT scan. So now again, nodules are broadly classified as 3 groups. An incidental lung nodule is a nodule which is picked up when a CT is done for some other reason. You do a cardiac cath and you pick up a nodule, or you do a abdominal CT and pick up a nodule, or you do a CT for breathlessness and pick up a nodule, like that. Second group is symptomatic lung nodule, where the lung nodule present with symptoms, maybe fever, hemoptysis, whatever. Third is a screen detected nodule, which is not very common in India because we don't have an official lung cancer screening program. So basically, if you have a high risk group and you're screening them for lung cancer and they pick up a nodule on CT, that would be called as a screen detected lung nodule. And the approach to each of these would be different. For example, a symptomatic nodule you would want to target anyways. But for incidental and screen detected nodule, you have to know when to intervene. Now comes the role of AI, which we will discuss in the panel also. Dr. Vipul will talk briefly about the AI in lung nodule detection. So once you pick up a nodule, you have to stratify them. This again, we will talk along with the cases, how we risk stratify them as being low, intermediate or high. And then you decide whether to wait and watch, do biopsy or do a resection. So this we will talk again. Once you decide to biopsy, again, you will have 2 options, either a CT guided biopsy or a bronchoscopic biopsy. Both are correct. Both have their benefits. Both have their flaws. Both have their setbacks. Again, this we will discuss in the panel. Now, this will be a very interesting panel because we have 1 radiologist versus 3 pulmonologists. So it will be a good thing to discuss as to how to go biopsying these nodules. Once you decide to do a biopsy, a bronchoscopic biopsy, then you identify the path. There are several ways to identify. Again, we have pulmonologists to help us, navigation, manual, so on and so forth. Once you know the path, you have to reach the nodule. That is where comes the role of thin bronchoscopes and several other technologies. Once you reach the nodule, you have to see the nodule. There, radiolibus, fluoroscopy, and now cone beam CT, all of these technologies are there, which will help us visualize the nodules. Once you see the nodule, you have to see the tool within. So that also we will talk about the concept of tool in lesion. That is where the cone beam CT actually comes into the picture and fluoroscopy. And then once you see the tool in the lesion where you want to do, you get the sample out of it. So again, a lot of ways you can sample them. You can do a ball, a brush, a forceps, a cryo, TBNA. So how to go about, we have pathologists also who will guide us as to how we can give them a better sample and how they can give us a better result. So again, once you give them the sample, they will analyze the specimen. That is step 8. So you can have analysis bedside, that is the rapid onset evaluation, or in the lab. We will discuss the pros and cons of each of these again. And if the pathologist confirms it to be a malignancy, you do simultaneous mediastinal staging, and now the future is going to be simultaneous fiducial marking. So that is the 10 steps in the evaluation of nodule by a pulmonologist. So that with this, I think this slide again briefly talks about the 10 steps, but we will discuss again at the ending. Okay, and the various gadgets which are used. So with this extremely brief overview of lung nodules, which I said I will finish in 10 minutes, and now we are 8:10. I think now we should go to the panel discussion. So I think it's a huge privilege for me to introduce all of my friends who are also my co-panelists today. So I will start with Dr. Samir Arbat. So Dr. Samir Arbat is from Nagpur. He's one of the most dynamic pulmonologists of our country. So he heads the One Healthcare. He's the founder, and he heads the One Healthcare pulmonology services at Nagpur. And what makes him so unique is that besides being such a great friend and a person, if you can see the logo behind him, so you can read that he's the ambassador, he's the global president of Media Committee of WABIP, and I'm very happy and proud to say that also not only for WABIP, for also for the APSR. He's the social media ambassador for ATS 2025, APSR 2023. So he represents India on the global front, and we're very proud to have you. Not only that, he is also an innovator, and he has a patent for the COVID safety box. So, which I very fondly remember, and we're very proud to have you here, Samir. And he's also an extremely good intervention pulmonologist. We'd all love to learn from him. Then we have another of my dear friends, Dr. Loveleen Mangla, who's from Delhi. So Dr. Loveleen is the senior consultant, and he heads the unit at Metro Hospital Faridabad. He's also a very astute clinician and intervention pulmonologist, and he also does all the complex interventions across all the metro centers in Delhi. So while heading his metro hospital, so he handles multiple interventions across the hospitals, and we are there and we're happy to have him share his experiences and views on the lung nodule approach and management. Then we also have our dear friend and colleague, Dr. Vipul. So we're happy we work together. So we are in Yashoda Hospitals, High Tech City. And Dr. Vipul has been with me for the last 5 years. And I'm very happy and proud to say that he's heading the nodule section of our hospital. So most of our nodule work is done by Dr. Vipul. And we are again happy to have Dr. Vipul. He will be teaching us a lot, I'm very sure. Then, as I've said, this is a multidisciplinary discussion. So I think I should again thank CCI for bringing in experts from other branches. Dr. Nikhil is there. So Dr. Nikhil Gupta is a radiology consultant. He is working at the Cibia Medical Center and Kuka Diagnostic Center, Ludhiana. It's always great to learn from a radiologist. So what a pulmonologist has to read from a CT, and how a radiologist can help us make our lives easier. And then the most important person I would say is Dr. Shilpi Dosi, madam. Because no matter what we do, whatever we do, the biopsy has to be interpreted by a pathologist. So having a good pathologist, having a friendly pathologist, I would say is the most important point to getting the correct diagnosis. And we're happy to have you, madam. Dr. Shilpi Dosi, madam, is a consultant histopathology at the BCM Kokilaben Dhirubhai Ambani Hospital, Indore. I think I'll welcome everybody. So we will all discuss cases. I will be presenting the cases, and then we will have discussion. So I will again share the slides. Okay. Are the slides seen?
Yes, sir.
Yes. Yeah. Okay. Okay. So now we'll be focusing on nodule in the Indian subcontinent. So in our country, with the resources we have, how do we go about? Okay. So as I've already introduced our expert panelists for the day. So this is the first case of a 26-year-old male, non-smoker, no comorbidities, presented with a right-sided pain, very vague pain for the last 2 months. His CT showed, CT was done for evaluation of the pain. It showed a well-defined soft tissue. I'll play the CT also. Okay. Oh, one second, sorry. Nodule 25 into 20, you can see here in the right lower lobe. Okay, this is the nodule which you can see. It's a lobulated nodule. Only one single nodule, nothing else. The rest of the lung parenchyma is normal. The same thing on the mediastinal cut. Okay, go slow here. This is the nodule. Splitting. I hope everybody can see it. Yes. So that is where we are. I think now we have a nodule. So the first thing is, when we have a nodule which we pick up on a CT, the first thing is defining a nodule. So I will start asking the panelists. So starting from the very basics, Dr. Vipul, can you enlighten us the definition, the Flischner's definitions of a nodule and a micronodule? What is the difference and why so?
Okay. Hello and good evening, everyone. So what is a nodule? A nodule is nothing but a circumscribed lung opacity, which is less than 3 centimeter or 30 mm in diameter. So why? So if you carefully see, the definition incorporates the fact that it's an opacity and also the size. Why size is important? Because any size which is more than 3 centimeter is what we call as a mass, which has a higher risk of malignancy. Whereas a nodule is something which is less than 3 centimeter and it could be high risk, low risk, or intermittent risk. There is also a subdivision for this nodule, which is a micronodules, which are nodules which are less than 6 mm. Why this classification? Because nodules which are less than 6 mm are probably inactionable, and hence it helps us to stratify nodules not just based upon the risk but also upon actionability.
Yes, thank you so much. So I think micronodule is less than 6 mm.
Yes,
Nodule is anything below 3 centimeters. So below 6 mm, usually we don't biopsy. So that's why they are classified as micronodules. Now we'll ask our radiologist, Dr. Nikhil ji. So when, as a pulmonologist, we pick up a nodule, what are the things that we should see, which we should document? Is Dr.
Good evening, everyone.
Yeah.
Thank you for such a nice question, sir. So on we'll be discussing CT mainly. On CT, the features of a nodule is like defining a mass in other aspects like size, shape, margin, location, presence of any additional pattern like calcification or necrosis within, or presence of fat content, or presence of other surrounding nodules, or architectural distortion surrounding the nodules, or the relationship of the vessels to the nodule. These all we see on CT. And most importantly, we see the pattern of calcification, on this. And we have benign pattern of calcification. Then we have malignant patterns of calcification, like speckled calcification or eccentric calcification are generally associated with benign malignant nodules. And the other calcifications like central, laminar, popcorn, diffuse calcifications are associated with more benign type of nodule.
Yeah. So as Dr. Nikhil has rightly said, when we see a nodule on a CT, it's important to document several features. The reason why we do it is these help in risk stratification. So some features favor a benign etiology over a malignant etiology, and so on and so forth. So now I will ask Dr. Samir, and others also can pitch in. So what features on a CT favor benign or vice versa? What features favor a malignancy? So Dr. Samir, and then others also can pitch in here.
Yeah, good evening, Dr. Nagarjuna. So I believe this question is very much applicable for the Indian scenario, because unlike our Western counterpart, benign nodules are way more common, and most of us, when we'll be starting biopsying nodules, we'll come across a lot of benign nodules, which is not exactly the case across Europe and US. So it's very important that we should be able to classify the nodule before planning for a biopsy. So mostly benign nodules are known to be smaller in size, somewhere between 6 to 8 mm. Very classically, they should be round, oval with very clean, smooth margins, because speculated margin is a definite characteristic of malignant nodules. And benign, as the name says, they are supposed to not grow. So if you're seeing a nodule which has been persistently of the same size over period of anywhere between 1 year to 2 year, it shows that it's a benign nodule. As mentioned by our previous panelist, any presence of calcification, any diffuse calcification, central calcification is also very much a sign of benign nodules, and also any fat content or surrounding centrilobular nodules will all favor for benign nodules as compared to the malignant ones.
Yeah. Yes, perfect. So I think just to summarize, I think this is what features of benign nodules: smaller in size, more likely benign; round, benign; smooth margins are benign; speculated is more likely malignant; upper lobe solitary lesions are malignant; non-upper lobe can be anything. And Dr. Samir has brought up this very important point of growth. I think this we will also discuss in the next case. So how the growth rate will help us stratify the nodules. And calcification patterns in India, Samir has rightly said, we come across a lot of fully calcific nodules. It's very common. Old TB, old infections, we see a lot of these things. And certain calcifications can be there in malignancy also. And fat is something which we should never miss. If you have a fat in a nodule, it would strongly point towards the fact that it could be a hamartoma. So now coming back to this particular nodule. So what is the panel's opinion? Anyone can now pitch in.
So, sir, it's a young male non-smoker, and although it's a relatively large nodule, but as we can see, it is a nodule with a very smooth margin. There is also specks of calcification and also a little bit of fat in the nodule. So, in all probability, it is screaming to be a benign nodule.
Dr. Nikhilji, do you agree with it as a radiologist? So, how do you define a fat density in a nodule? This is for the general pulmonologist.
Fat density is generally anything less than 100 HU.
So I think the HU is
around minus 100 HU.
Yeah, correct. So HU, many times in CTs it is not mentioned, but we should make sure that we look at the HU. This particular nodule has a very low HU. So this was actually presence of fat, calcium and solid component in the nodule, which I was showing about. So what would be the panel's discussion? Do we biopsy and give it to Dr. Shilpi madam, or do we not biopsy this thing? So is it definitely benign, no biopsy, low risk? I think Dr. Loveleen can answer this question, and others can either raise their hands or say or counter. Dr. Loveleen is there? Dr. Loveleen is not there. Dr. Samir can answer.
Yeah,
what would be your decision on this thing? Do you biopsy or not? This is a nodule. This is a case would come to us.
Yeah, we should also take into consideration the size of the nodule, because it's almost approximately 20 mm by 25 mm is what we know the size of the nodule. So I think so we should go ahead with the biopsy. What do you feel?
Dr. Vipul, Dr. Loveleen, your opinion?
I feel because he's a young male, I think non-smoker, 26 years, and smooth margin, fat is also there in this, plus calcification eccentric. I think we can just wait for him because he's giving some symptoms. Vague pain is still there. So we may keep in the low risk and just we can do a serial HRCT test. Although size is against for us for the biopsy, and like we should biopsy for the size. But other characteristics are like of a patient which is of a low risk, and we can just wait and do a serial HRCT.
So this is the real world scenario. So in a nodule, when it is there, there might be different opinions. So everybody is correct. The size is large. But Dr. Loveleen is also correct that you have a fat and a calcium density, so it's more favoring a hamartoma. We had an MDD in our hospital also. So the radiologist also was a strong opinion that this could be a hamartoma. So we looked at the previous scans. He had a scan 2 years ago, and it was exactly the same size, same features. So that is when we labeled it as a pulmonary hamartoma, reassured him and sent him back. So this case was labeled as a benign nodule and it was not sampled. Had we not had the earlier CT, you would have biopsied and then maybe you would have given it to the pathologist also. Now coming to the second case, but that case, because there was no growth and a typical hamartomatous features on the CT scan, we did not biopsy the nodule. So this is a 44-year-old male, again non-smoker, no comorbidities. It is a health check. It's a very normal health check done. These days in CT is also being done in the health checks. So he had a nodule which was picked up. Just come back. This is the nodule. Hope it is seen there.
Yes.
It's a small nodule,
Yes.
absolutely brilliantly round, smooth, homogeneous nodule which was picked up. And as Dr. Nikhil has rightly said, so we started documenting all the features. Dr. Nikhil, I hope we are correct in all these things.
Yes,
Solid,
definitely.
yes, solid. Can Dr. Vipul also tell me what is it between solid, subsolid, and ground glass nodules? How are they different?
So this is a very important thing to look at CT. Subsolid nodules is a nodule which has a ground glass nodule is a nodule which has a very low attenuation. So probably these are lesions which are very slow growing and would require a lot of long-term follow-up. Whereas a solid nodule is the one which has a very high attenuation and we are not able to see any lung parenchyma or vascular margins behind it. So these are the lesions which are probably have more potential to be malignant. So risk stratification for these nodules are important, and a follow-up for us ground glass or a subsolid nodule is very important because they tend to grow very slow. So for us to follow up them, for the follow-up would be like instead of the normal 3 years for a solid nodule which is not growing, follow-up for such lesions would be up to 5 years.
Correct. So solid nodules grow little faster. Ground glass grow very, very slow, and subsolid intermediate. Subsolid is the one which has the highest risk of adenocarcinoma, and ground glass is more of adenocarcinoma in situ and so on and so forth. But in India, I think most of the nodules which we tend to pick up are solid nodules. Size is again important. So this case, it is 11 mm into 10 mm, round, smooth, and there is no CT bronchus sign, no cavitation, nothing else. So this was the nodule which was there. So this case, obviously, when he came, it was labeled as a benign nodule of all the features, no risk factors, nothing. And then again, another PET was after 1 year, a CT scan was done. So again, you can see the nodule almost the same. So now 1 year has elapsed and the nodule still remains the same. Now, so when we have a nodule on a CT, so how do you measure the size of a nodule on a CT? Again, Dr. Vipul can answer this question.
Okay, this is one of the most important facets of a nodule is the size of the nodule. What one must realize is usually what we do is we always see the nodule in an axial plane, but a nodule can grow in other planes as well, maybe the coronal or the sagittal. So it is always important to see the nodule in all the three planes and determine the plane in which the nodule is at its maximum size, because it need not be that the nodule might grow in the axial plane itself. So to measure the size, first determine which plane the nodule is at its maximum. And then for nodules which are say probably more than 10 centimeters or larger nodules, always measure the short axis as well as the long axis and measure it along with the actual measure it along with the plane in which it was measured. For nodules which are probably smaller in size, we could just take the average of both the axes and then can document it.
So basically, the short axis, long axis are different, small, long, and the average. I think we should document everything in the plane in which it is the largest. That is what people tried to say.
Yes.
That is important because many times we don't are not very meticulous in it. And Dr. Samir was talking about in the last case the growth of a nodule. So Dr. Loveleen bhai, so doubling time. What is the concept of doubling time, and can you explain it for the audience? Why is it important?
So doubling time is a time which is required to a nodule to double its size. So basically, it reflects the growth rate and the malignant potential of that nodule. So we take ideally we take 20 days to 400 days, which is an ideal time. If the doubling time is between the 20 days to 400 days, we call it as a high malignant potential. But if the doubling time is less than 20 days, we think it is more of an abscess or tuberculosis. If it is more than 400 days, we can take it as an hamartoma or maybe some granuloma infection. But if any nodule which is stable for 2 years, then we can label it as a benign etiology also. So doubling time definitely helps us. And if you are not able to assess the doubling time for some patients, if any diameter increases there more than 2 mm also, or maybe 26% increase in the diameter also, that also correlates with the doubling time in these cases.
Correct. So doubling time means doubling of the volume of the nodule. As Dr. Loveleen has rightly said, if a nodule is doubling very, very fast, then again it's likely to be a benign thing. Or if it is growing too slow, that also is likely to be benign. as rightly said, most malignant, I will say again, most malignant nodules have a doubling time between 30 to 400, 20 to 400. Different people say different things. Roughly, that is the doubling time for the nodules. So, Dr. Samirji, so how long should you follow a nodule to label it as benign? What do the guidelines say? Dr. Vipul has slightly touched upon this thing, but can you just detail for us?
Yes, so to label a nodule to be a benign nodule, we need to at least follow up for 24 months, that is 2 years. But again, we have to take into consideration what was the size of the nodule when we start. If it is a very small nodule, or like we mentioned, if the nodule, if there's GGOs, so we have to consider for also the patient, whether patient is a low risk, high risk. But mostly we see that 2 years is a time when we can actually label the patient to be having a benign nodule.
Okay, 2 years is the number we have to remember. I think so. The index case also 1 year elapsed, no growth. Probably another 1 year, no growth. We label it as true benign. But if it's a ground glass nodule, we should wait for 5 years because they grow slower. That is the only difference. A ground glass nodule, subsolid nodule, 5 years. A solid nodule, Samir has rightly said, 2 years is the time which we should follow before we label it as truly benign. And we're all talking about volume of the nodules. But as a pulmonologist, I cannot determine volume on the CT scan. I can only measure the diameter. So, Dr. Nikhilji, how can radiologist help us in finding the volume?
The volume is very simple to measure. It is like we take two diameters in axial, the AP and transverse, and one diameter in either cornel or sagittal plane. That is CC diameter. And then we multiply all these, and then we multiply it by a factor of pi by 6, which comes out to be roughly 0.52. Or we simply multiply all the three and divide it by 2. So it comes the volume.
Oh, wonderful. This is a new information for all of us because some softwares give the nodule, the volume of the nodule. Some softwares don't give the volume of nodule. But then if you listen, Dr. Nikhil, can I repeat two planes, AP transverse, and one in the another?
One in the CC.
Yeah, CC.
Quadrennial.
And then
Linear
and divide by 2. Multiply everything and divide
multiply all three and divide by 2. It's a rough estimate of volume. It is actually for entirely spherical body.
I understand. Yes, exactly.
Yeah.
So
it may be elongated, but it gives us a rough estimate.
Yes. So now there are a lot of guidelines which have come across. So Fleischner guidelines, this is how we should measure the nodules. For those who want to take a snapshot, you can take a snapshot. Then how, again, this is very important. Dr. Loveleen has said this point. 2 mm increase in nodules is considered significant, any size. If it is at 1 year gap, there is an increase in 2 mm. The RAD say 1.5 mm, the Fleischner says 2 mm. That is considered to be a significant growth of a lung nodule. So now this is the facts which Dr. Loveleen has already said, but just to repeat, an increase in diameter by 2 mm is significant. An increase in diameter by 26% correlates to doubling of the nodule, and the doubling time is anywhere between 30 to 400 days. So now in this case, the case which I had shown, 2 scans, 1 year apart, no growth, and all the features of a benign nodule. So now what will the MDD say? So Dr. Vipul, Loveleen, Samir, anybody, and Dr. Nikhil. So do you say that it is benign and stop following? Do you want to follow for 1 more year? Do you want to do a biopsy? What is the plan?
It's a solid nodule, so follow up for 1 more year.
Yes, Dr. Nikhil says follow up. Everybody agrees?
Yes.
Yes, I think because it's a very nice, smooth nodules, I think we should understand that there are several nodules like this which we see where we just follow up. So this case also, we didn't do anything. We asked him to come back after 1 year. So 2 years over and then we will stop following it completely. So this case, 1 year follow up over. In the next year, probably he will come back and then after that we won't follow him again. So the third case is a different case. 71-year-old gentleman, multiple comorbidities, hypertension, diabetes, Parkinson's. He has 2022, he has a peripheral leiomyosarcoma of the right shoulder. Resection and adjuvant RT were given. So this was the scan, surveillance PET scan after 1 year. There it is. It's a small nodule. Here you can see here. There is a small nodule of 7 mm which is picked up on a surveillance PET scan. This is a peripheral nodule. Okay. So now when we have a nodule, again, we've discussed a lot about the radiological features. Now we will talk about the clinical features, risk stratification. So again, last Dr. Samir. So what are the clinical predictors of a malignancy? Clinical predictors, not the radiological predictors. So this is again important for all of us to know.
Yes, so I think so. This is something that a lot of us have first learned during our medical school is what is a high risk for a patient with malignancy. So very much similar we have for a malignant nodule also. So patients who are mostly above the age of 50 years, patients who are smokers, patients who've had a past history of malignancy. At the same time, if the patient is already having a known malignancy, thoracic malignancy, so these are some of the very strong predictors for a malignant nodule. And also patients who have other comorbidities such as COPD and family history of malignancy. So these are all the patients who, if they present with a nodule, we need to consider them having a very high risk of malignancy.
Perfect. I think so. What Samir has summed up are these: age, smoking, occupation. This is very important. Past or current malignancy. You should have very high index of suspicion. If a person has a past history or a current exothoracic malignancy, family history of malignancy also is important to ask. Associated COPD or symptoms. This is all the important clinical predictors of a high risk nodule, I would say. Now, are there any scoring systems or risk prediction systems which can guide us? So, Dr. Vipul, can you throw light on this thing? You are muted. You are muted. Vipul, you are muted.
Okay, as Dr. Samir sir has rightly mentioned, there are various clinical parameters that can determine what are the indicators for malignancy. So there are certain risk scores which have come up, which incorporates all this clinical data, be it age or smoking history or history of malignancy or locate, and then the lesion characteristics on CT, be it the nodule size, the location, presence of speculations, and a lot of risk prediction scores have come. So if we can broadly classify this risk scores, there would be clinical scores, guideline related scores, radiology related scores, and now there are this AI system related scores as well. So when we talk about the clinical scores, the most initial models which had come were the VA risk model, which was basically nothing but hospitals in the US, wherein they would take these veterans and they have this screening data. So these models where they incorporated a lot of clinical information, and then they came up with a risk score. The more commonly used models which we see are the Mayo models, which we usually use in our clinical practice, wherein any nodule on CT we can risk stratify. And adding to a Mayo model, then there is this any patient with a nodule picked up on a CT would probably go on to get a CT scan and or maybe a PET scan, and we can incorporate the Herder model into it. And there is this Brooks model which is used in countries where there's a lot of screening which happens. So as a part of the screening, they will just get a low dose CT scan done, and then these patients would undergo this Brooks model risk assessment to risk stratify and then decide what can be done. So these are the various.
Yeah, I will just interrupt. So there are a lot of risk prediction scores, but do you think they're applicable in India? And has anyone been tested in India? That is what we are actually concerned about.
So
how relevant are they in the Indian practice?
True, as rightly said by sir, in most of these Western countries, most of the nodules what we pick up are probably malignant. They don't face a lot of benign lesions. Whereas in our country, we see a lot of burden of benign diseases and most of the nodules coming benign. So most of these risk prediction scores are actually not 100% clinically relevant to us. It just maybe help us
So
a
I think
little
that
bit in
is
decision
the
making.
echo message that though we have a lot of these, so it's important for us to know that we should not apply them blindly in our country because none of these have been validated in our country. And we are trying to look at our data and see which of these would actually represent or which will be valid in our country. So I don't think any one of them is applicable to our country at this point of time, though there are a lot of them. This is important for us to know. Now also, these Fleischner guidelines and lung rats guidelines is two are there. So again, Dr. Samir, Loveleen, or Dr. Nikhil, anyone can say. So when to apply these guidelines? So these are freely available online. So Fleischner guidelines for solid, for ground glass separately are there, and you also have this lung rats guidelines. These are also there. So Dr. Samir or Dr. Nikhil, can you tell us? So in which population should we use this?
I think so. We already know that Fleischner's is not supposed to be used for patients who are below 35 years of age.
Yes.
Agree? Yes. And Dr. Vipul, anything from your side?
So with regards to these guidelines, again, like I said, if they fit into the correct clinical context with regards to the exposure history, age, and all parameters, then definitely these guidelines can do really help us in risk stratification and at least give us an intention to biopsy. Probably lesions which are between 6 to 8 lesions which are low risk definitely could be followed up. And at our center, patients with high risk and lesions more than 8 we definitely go ahead and try to get a biopsy done.
So what the thing is each of these guidelines are meant for a particular group of nodules. The lung rats is specifically meant for screen detected nodules. So in countries where you have a lung cancer screening program, so already they are high risk. They are smokers 55 to 75 with a particular pack years. So clinically they are in high risk. And then you apply the lung rat CT classification to further risk stratify them. Dr. Loveleen, आपको बोलना है?
Another thing which is important when we talk about the scoring systems, can we switch on this slide of scoring system? Is that most of these they have taken the location of a nodule, like the upper lobe location they have taken as a positive. But in our country, we will see the more of tuberculosis. And past history of tuberculosis and all these things are important in our scenario. And many of these patients will have upper lobe nodules. So this is an important thing which they don't take consideration is previous history of tuberculosis. So when if you are using these models, we should also take this previous history of tuberculosis, and we should again see, because we see more of tuberculosis as a nodules and they see more of a malignancy as a nodule.
Bang on. I think when we create an Indian scoring system, past history of TB will be there. Definitely.
Yes.
Also, I believe symptoms of anorexia and weight loss is something for them. It is a very clear-cut sign of malignancy.
Correct.
But in India, I think so. We go by the rule of tuberculosis, which is very much true, as in.
Very true. In fact, several nodules come out to be granulomas in our country. So all of us are very, very correct. So coming back to this point, so lung rats is only for screen detected nodules. Fleischner's is for incidental lung nodules. So both of them are not for symptomatic lung nodules. If you have a symptomatic lung nodule, you sample it any which ways. So this is all there on the web. So I don't want to go through all of these things. So lung rats classifies them into 0 to 4x. And Fleischner's, this is something which is because most of the nodules are also incidental nodules, which we see. So the broad thing is rule of 6 and 8. Below 6, usually don't do anything. Above 8, you are vigilant. 6 to 8 depends upon the risk. That is what I usually say. 6 to 8 and 8 is what we have to remember, the millimeters diameter, which is important for us. And Samir was talking about this thing. So young age not applicable. And none of these Fleischner guidelines should be applied in patients with malignancy and immunocompromised host. Immunocompromised host is a different subset. High risk of infections, high risk of lymphomas and other things also. Okay. Now in this case, in the index case, so because he had an extrathoracic malignancy, sarcoma, so it was decided that we have to closely follow. In fact, the patient was called after 3 to 6 months after 2023. But in India, it always happens that patients often take their own decisions. So he came after 1 year. And then again a PET was done. So now what happened is this is in the span of 1 year, it has significantly grown in size. So definitely there is a growth of the nodule over 1 to 1.5 year, I would say. Now this is the size of the nodule. From around 8 mm, it has become 26 mm. So 1.5 times. Now it is lobulated, the past history of malignancy. Now what would the panel do? So option 1, benign. Option 2, biopsy. Follow-up. Option 3, biopsy. Option 4, direct surgical excision. Dr. Loveleen dear, in Delhi, what would you do? Then Dr. Samir will tell in Nagpur and Dr. Vipul will tell in Hyderabad.
Definitely go for the biopsy first.
Yes, so biopsy is definitely not the wrong answer. Dr. Samir, what would you do in this
Yeah,
case?
I think so. At least for the audience, we should believe and work with an MDD. So
Correct.
that is one very important thing. I might call up Dr. Nagarjuna and take his opinion on this particular case.
So
But yes,
Dr.
we
Nikhil
need a
bhai,
radiologist on board,
yes,
definitely.
so Dr. Nikhil ji, now this case तो भी the first two cases were simple, we were not biopsying, but इस पे क्या करेंगे?
We should go for a biopsy. Yeah.
Correct. So I think that is definitely the answer, but our people were even more aggressive in Hyderabad. So the surgeon directly took him up. He said that it has to be malignancy, nothing else. So when there is an extremely high risk of it being malignancy, you're also not wrong in directly taking up for excision biopsy. So that also is there. So in this case, I think both are correct. Obviously, option 1 and 2 are not correct. You cannot leave the nodule. You either confirm it by doing a biopsy and then treat accordingly, or as our surgeon has decided. So it was actually under the follow-up of surgeon. So he had the higher hand then. So he directly took up for excision biopsy. He did a nice wedge of both the segments because this was a recurrence. And then it turned out to be a recurrence of the sarcoma, earlier sarcoma. So now we have discussed 3 cases. First case is a definite benign. Second case also was follow-up. Third case was an extremely high risk where direct surgical excision was performed. Now we'll come to the fourth case, male. They have to be a little far. Hypertension, diabetes, pleural TB. And there is the nodule there. You can see the nodule, just come back. So before we discuss about this nodule, I will also want to involve our pathologist on the previous case. So in case there is a nodule, Dr. Shilpa madam is there.
Yes.
So if you have a nodule where we cannot biopsy, but we suspect malignancy, is there a role of liquid biopsy?
So in previous case, definitely not, because it is a known case of sarcoma.
It's a sarcoma, but
Yes,
it's a primary
sarcoma.
nodule. Yes,
Yes, the
suspecting a
pulmonary
primary
nodule.
lung.
Liquid biopsy is a complementary test for a tissue biopsy. Tissue biopsy is must for diagnosing the lung cancer. But where in the high risk cases and when the tissue biopsy is not adequate, then liquid biopsy, because it is a non-invasive test and there are several components like circular tumor cells and then cytoplasmic free DNA test. Latest is micro RNA. There we can detect the cases, but I have searched the literature. The most of the time, in the advanced stage, these tests are applied, and the utility of these tests at early stage is still not well defined. But definitely in cases where tissue is not sufficient, and in the old age where the cancer is higher chances of, you will definitely go for liquid biopsy.
Thank you so much, madam. So this is something where research is evolving, I would say. So thank you, madam, for reiterating the fact that biopsy still remains the gold standard. So all of us are happy that we get to do biopsies, but probably in a decade or two, the liquid biopsies will take over. I think it's the time we should embrace the change, I would say. But as at this date, it's the biopsy. Only if biopsy is insufficient and you can't do a biopsy, comes the role of liquid biopsy. That is how I would put it. Now, coming back to this index case, he had constitutional symptoms of fever, dry cough, and this is a nodule which you can see in the middle lobe. Middle lobe? Yes, and then there's some more nodules also in the right lower lobe and the left lower lobe. So quickly I have to go because we are running short of time. PET also was done. This was the index nodule. So one very important feature here is the airway. Hmm. So now we'll talk about the airway. This is something which I feel is extremely important. So very quickly, we'll have 30 seconds. Vipul,
Yes.
doctors, what is CT bronchus sign?
So a positive.
What is its relevance?
Yeah. So as you can see, a positive CT bronchus sign is a sign in which a visible airway appears to directly communicate with the nodule. So it can go and abruptly stop at the nodule, or it can go through the nodule, or it can just abut the nodule. In this case, as we see, it is going through the nodule. We have this beautiful CT bronchus sign. So what is the importance of this is, once we have a positive CT bronchus sign, it means that we will be able to bronchoscopically navigate to the lesion easily, and we should be able to localize it using a radial EBUS, and probably we could also get a nice biopsy.
Thank you so much, Dr. Vipul. So this is a very important thing for a bronchoscopist. For a radiologist, it doesn't matter because they will reach it by hook or crook. They will puncture the lung and they will go there. Bronchoscopist, if a CT bronchus sign is there, then I think the chances of diagnosis or reaching the nodule is much higher. So we should always keep a very vigilant eye for CT bronchus sign. So anybody, the types of nodule airway relationship, I think we will not spend too much time on this thing. And I will just go through these images. This is for all to see that there, as Vipul has said, there are several types of CT bronchus sign. It can stop at the nodule, it can taper, it can go through and through, it can just go by the side, or there is no airway nodule also, which means there is no true airway. A nodule is separate from the airway. So from here, from the left to the right, the diagnostic yield steeply comes down. So if you have a direct airway, 80 to 90% you will get a diagnosis. 2C means there is no airway going to the nodule, so bronchoscopy is best not attempted there. So this is what I wanted to say, that how to choose a patient for bronchoscopy is depending upon the nodule airway relationship. Now coming to the practical question, Dr. Loveleen. So after doing so many bronchoscopies at all the centers of Metro, so how would you decide based on CT which case you would have a higher chance of getting a bronchoscopic diagnosis?
There are multiple things you can see, like if size is more than 2 centimeter, the lesion if more of central towards the hilum, if it is a solid lesion also. Then another thing which is if it is bronchus sign is positive or not. We should, whenever we are planning for any these interventions, we should go to the CT room. Maybe we should visualize the CT scans again and again. We should look for any airways, and we can if map any airway which is leading towards this lesion. This is the most important part before taking in these patients for any radial EBUS or for the procedure. If your bronchus sign is positive, then definitely you will get it a good
now
diagnosis.
I will ask the same question to Nikhil bhai. So what features on CT are you happy doing a biopsy? And when you would say, I will give it to the pulmonologist?
One of the main
smiling and they're
it
waiting
should
for
be
the answer.
peripheral. It should be peripheral, large, about 1 to 2 centimeter, and it should be away from the bronchus. So the best we'll do it, for the patient is that we do a CT guided biopsy. But if it is near the bronchus, a small lesion, and bronchus is directly ending into or passing through it, or any of those, so better to go for a bronchoscopic.
I think we have a very friendly radiologist. Correct. So I think one thing which both said is that size. So larger the size, easier it is for anyone to biopsy. Correct. That is one thing. Second is the location. The more close it is to the pleura, the more easier it is for the radiologist to do. If it's in the middle 1/3, I think that is where the bronchoscopist has the highest control, the central or the middle 1/3. I think the size of the nodule, the location, central, middle, peripheral 1/3, and airway, whether you have an airway to it or not. I think these are the three things which would actually determine which modality. Loveleen, anything else?
Another thing is we say whenever they have to, if nodule size is less than 1 centimeter, if we want to specific in this. And another thing is when they have to pass a needle more than 4 centimeter, and then only the diagnostic aid decreases a lot.
Yes. So now from Dr. Shilpi Madam, again from the pathologist perspective. So what do you expect from a pulmonologist? Now we're slowly moving to biopsying the nodules. So what? See, many times we just send a biopsy and don't write anything, don't tell you anything.
Yes.
Is it fair to test your
This is
skills,
a
or do you
very
want any
common
information?
problem, and we pathologists always very notorious. Are yaar, you are always asking for the history. Give you what you see. So history is important because it's history of smoking, history of any comorbidity, history of weight loss and loss of appetite is important, and
Madam,
history
but
of
won't that make you biased?
no, it don't make me biased. And history
Okay.
of lymph nodes. History of lymph nodes is very important because sometimes when you do biopsy from the mediastinal lymph node, and I see these small round cells, and if there is a lesion in the lung before in hand, I have the history, then my diagnosis go towards small cell. And if there is a generalized lymphadenopathy, there is diagnosis go towards the lymphoma. Then there is this radiological imaging is the must for us because it is a location, size,
Yes, I understood,
and
madam. So I will just summarize it for all the pulmonologists who are here. So please give a history to the pathologist because
yes.
that will help them. They will not bias them. It will help them give a correct
And
diagnosis.
what is your clinical suspicion?
Yes.
Actually,
And our
my
pathologists are even
80%
smarter,
of
madam.
the diagnosis will be 100% in your favor if your clinical suspicion is there.
Yes. So yes, but our pathologists are very smart. They directly access the HIS.
Yes,
They
I
will
have
give the
also,
radiology and everything, and then
I
they will
also
do
have.
it. So anyway, so that is important for the pulmonologist to give history to the pathologist. Okay, that is something which I wanted to say. So in this particular case, actually this turned out to be an organizing pneumonia. Finally turned out to be an autoimmune cause. So I will stop staring the screen. We have two more cases. I will also request anybody who have questions to please post the questions. We have a lot, but we will choose which questions we want to take up. So as I share the next set of cases, we have two more cases to discuss. And before we go on to the second case, message from the founder member and our very dear senior Anna is Dr. N.S. Krishna is that there are around 2,000 people logged in. So 2,000 people viewing the webinar. Thank you so much. So this is the next case, a 74-year-old male, non-smoker, hypertension, airway disease. Again, if you see hepatocellular carcinoma diagnosed in March 2024. Initiated on therapy. This was the March scan at the time of diagnosis. So no lung lesions. Then after 3 months, a repeat scan was done. I think after some chemotherapy, he has done a scan. You can see here now there is a nodule. No, this is a 7 into 10. So average will be around 8. But here we cannot apply Fleischner guidelines because it is there is extrathoracic malignancy. So this would obviously go for a very high risk nodule. So these are the nodule characteristics. Dr. Nikhil has already told us that we have to look at all these things. So we are all following Dr. Nikhil and documenting all these things, the size, shape, margins. Here CT bronchoscopy is not there. So Vipul is upset that we won't be able to reach the nodule. CT bronchoscopy is not there. Now what should be the plan? The MDD. So biopsy, no biopsy, which biopsy? So I will ask one pulmonologist and one radiologist, Dr. Samir and Dr. Nikhil. So which biopsy would you do? CT gated, bronchoscopy gated? Dr. Samir is there?
Yeah, so first I'll mention, I think so our discussion was whether we should biopsy or not. So definitely this patient has a extrathoracic malignancy, comes as a high risk patient. And now we are open to the question, should a bronchoscopist do a biopsy or a CT guided biopsy?
So this is the golden question now.
Yes, looking at the size and the location, if we have a competent radiologist with a center which is already performing regular CT guided biopsy, the fact that we don't have an airway leading to this lesion, I can judiciously suggest the patient to go for a CT guided biopsy.
Wonderful. Dr. Nikhil ji, are you ready to take up this case?
Sure,
Dr.
sir.
Samir has referred from Nagpur to you. So will you do a CT guided biopsy?
That it is a perfect candidate for a CT guided biopsy. Uh, Peripheral lesion,
Yes.
no bronchus nearby.
So, Dr. Vipul, would you want to do some airway tunneling and reach the nodule, or will you give it to the radiologist?
Sir, in this case, probably I will give it to the radiologist.
Yes, I think we all will agree with the fact that this is a nodule which is absolutely close to the pleura. So, this is a nodule which ideally should go to a radiologist. So this is what we also have done. But then, so this is a clear-cut case. But now I will ask Dr. Nikhil. So, what are the advantages of CT guided biopsy?
Well, we take a bigger needle, like it is a 16 gauge or 18 gauge needle. So we get a better yield. But and it is a lesser cost than bronchoscopic guided biopsy. And also, there are chances of complications are more.
हम आपसे advantages से पूछ रहे हैं. Complication बोलने के लिए बहुत there lot of people are smiling and waiting to tell the complications. So as Dr. Nikhil has rightly said, the needle size. No, Samir is the cool guy. He will tell BioPro will give you much bigger pieces than what your needle can give. But then yes, the biopsy is there. So now Dr. Vipul will counter Dr. Nikhil and say what are the risks of CT guided biopsy.
Although Dr. Nikhil says we can get a CT guided biopsy done, it is easy, cheap, whatnot. But then obviously there's so many complications which can arise. One is the risk of pneumothorax obviously is much higher in a CT guided biopsy. One. Second thing, in case if there is a bleed, there is no way we can control the bleed. That is something which is a major concern for me. Third thing would be it is a guy who has a single metastasis, probable metastasis. So when we do a biopsy, probably there is a chance for seeding of the lesion. And in case, although this is a high risk case, maybe not pertinent to this case, but if it were any other case wherein we do a biopsy here and if it turns out to be a benign lesion, there is no way that we could perform other microbiological tests which we would have otherwise performed had we done a bronchoscopic biopsies. So these
Dr.
are the
Samir, yeah. Any comments on this needle tract seedling? How relevant it is?
So we've been having these papers published since the 1990s regarding cases where patients who were followed up after a CT guided biopsy after a period of 3 years and 5 years, and there has been noted cases of tumor seeding across the passage of where the CT biopsy needle has gone. I think so. It's a very pertinent point, needs to be taken into consideration. But in India, we also have to take into account the cost and other options. I think so. We should mostly focus on the location, the airway passage to and the size of the nodule.
Yes. So I will support Dr. Nikhil for a while. That CT guided biopsy has advantages. Yes, definitely. It has a high diagnostic yield. In the sense, a normal bronchoscopy center will not be able to give you 90% diagnostic yield unless until they have all the tech gadgets. Cost definitely lesser. Many centers have access to CT guided biopsy. Very few centers have access to bronchoscopic biopsy. And the CT to body divergence. I think this we will briefly discuss later, which is not there because they're doing real-time CT. They do CT there, they do the biopsy. There is no question of CT body divergence, which happens when you do a CT before and bronchoscopy later. So that is another problem. So, and the important thing is that they don't need an airway. The full lung is their zone. So they can puncture the lung parenchyma and go. That is why they have a high diagnostic yield. And Vipul has said now that CT guided biopsy has higher complications. So now advantages of bronchoscopic sampling. Very quickly, Dr. Loveleen,
Yeah,
Dr. Samir,
so-
anybody?
Yeah, so
I'll
yes, Dr. Loveleen, please go ahead.
No, I'll give you less pneumothorax, less
Yes,
control,
yes.
better control of bleeding, no tract metastasis, and fourth thing, I can give you the bowel sample also for to rule out any infectious disease.
Exactly. So nicely and crisply put. Dr. Loveleen के पास जाएंगे तो
Staging,
निको नहीं
staging.
होगा. So no pneumothorax. Even if it
Yes.
bleeds, he can control the bleed. He can take a ball. He can do simultaneous staging. I think these are the precise benefits of a bronchoscopic sampling. But what are the negatives of bronchoscopic sampling? Is that the cost? Definitely much, much 3 times costlier than a CT guided biopsy. And not everybody has access to Dr. Loveleen or Dr. Samir, correct? So that is another
But
problem.
Dr. Nagarjuna, one more point. If the CT center is not well equipped to handle a complication,
Yes.
then maybe we might be not doing right for the patient.
I
So
think that's an absolutely brilliant thing, Dr. Samir. Thanks for bringing it. So we have had instances where they did a CT cat biopsy, hemoptysis, rushed to the emergency. We had to handle it. Suppose it was a standalone radiology center and something happens, then it will be a major problem. So you should choose your cases wisely. That is what I would tell. These are the basically both have their pros and cons. So, but bronchoscopic biopsy, another con is the yield. Now we are reaching close to 90, but it needs a lot of steep learning curve, which is there. And for all of you who are listening, there is a good article published in NEGM very recently, the bronchoscopic sampling versus CT guided sampling. Now the yield is almost the same. The complications are lesser with bronchoscopic sampling. I know, Dr. Nikhil, we outnumber you today, but then we will still support you by sending a lot of cases. So this is my summary of the CT guided versus bronchoscopy. Both have their pros and cons. The other thing which we have not discussed is the bronchoscopic sampling needs a much deeper sedation than CT guided sampling, usually GA. So people who are very, very sick who cannot undergo a procedure like this, we cannot do a bronchoscopic sampling. Okay, so because I think we are having one more case to discuss. So this is the last case, I would say, 58-year-old female, asthmatic, May 2023. This was a scan which was, we went back retrospectively and got this CT scan. So at that point of time, this scan was labeled as normal. So carefully, there was a small ground glass opacity which was there, which was missed. In July 24, also, this was not for, she came with bad asthma exacerbation and a CT was done. And now this is what was there here. So now, Dr. Nikhil, can you just comment upon this particular nodule?
This is
This is unlike the previous nodules.
yes. This has grown in size. The ground glass area has grown in size with a soft tissue component.
Correct. So this is what we call as a subsolid nodule, where there's a solid component and a ground glass component. Okay. The 2 years, 1 year back, it was only pure GGO. Now it has become from pure GGO to a subsolid nodule. So now this is what the features were like. Now this, we also used all these Mayo score, this score, that score, and all. This is more for theoretical reason. Now in this case, so would you, before we go on to this thing, how many of us would biopsy the nodule? Vipul, Loveleen, Samir, Nikhil bhai, yes. So I think this time Dr. Shilpi madam is going to get a tissue anyways in the first case and this case also. So now again in this case we were discussing with the radiologist. So radiologist also was ready to sample it. We were also ready to sample it, but then the patient did not accept a pneumothorax. So in this case, the first case we did a CT guided biopsy. The previous case, the peripheral nodule, it turned out to be a metastatic HCC. In that case, this case, because the patient did not accept the risk of pneumothorax, we took up for bronchoscopy. Now, very, very briefly, Dr. Loveleen, how are the brief steps in bronchoscopic planning of a lung nodule?
First, we need to identify the path to the nodule. We have already discussed about we need to look into the CT scan. We need to size the location of the nodule and path to the nodule through the bronchus sign if it can be positive. Then we will navigate our bronchoscope, maybe the ultra thin or thin bronchoscope, and to the lesions. And once we are able to reach there, we will visualize the target through the radial EBUS also. through the radius. After that, we will visualize the tool in the lesion. It can be done through the fluoroscopy, or it can be done through your navigation bronchoscopy, or sorry, navigation or fluoroscopy, or maybe through the CBCTs also. And after that, we can do the sampling through the multiple forceps, biopsies, BAL, or everything we can do. These are the 5 steps.
Absolutely brilliant. Identify the path, navigate the path, see the nodule, see the tool in lesion, and then do the sampling. Brilliantly put. Now, Dr. Nikhil, how can you help a pulmonologist? How accurate will be in CT to help to reach the nodule?
We can do CT guided.
नहीं वो तो अब इस पे कर नहीं रहे हैं. We the patient refused. So now, how can you help the pulmonologist? Can you give us a path?
Yes, sir. Through the airways, we can do that.
Yes. So I think we should all sit with the radiologist, see the scans, and then understand how to reach. That is called as manual mapping. But Dr. Samir is there. Samir now is the global representation of India. And can you tell us about navigational bronchoscopy? Very briefly, what it is and how it can help us.
I'll keep it very short. So the most easily available and useful gadget is our brain. So manual mapping has been shown to be very effective. So first is you should learn how to map. A very essential and a very easily available tool is radial EBUS. So radial EBUS will help you to reach the tool. Then there are some advanced technologies which are available in India, which are available outside also. First, we start with virtual navigation, which is like a Google map. Basically, there is a preloaded CT. Then you go inside with your bronchoscope. It will tell you whether you should go right, left, up, down, that sort. So that is something called as virtual bronchoscopy. There is something called as cone beam CT, which is a real-time imaging wherein you can make sure that you are inside the lesion and you can get it as a real-time image. And what Dr. Nagarjuna has is Archimedes, which is again a software which will tell us a pathway to go to a lesion. If there is no airway, then we can do a tunnel without any damage to the vessels and reach via tunneling. So this is a very simplified way of telling the navigation tools, which I believe as of now you should know. Anything beyond this is best not known for our knowledge.
At this point of time, yes, in India, so virtual bronchoscopic navigation is something which we should know. So in India, we have now 2 VBNs. One is the lung point by Bronchus and Synapse by Fuji. So both of them are exactly Google Maps. So yes, they take the CT, they give the path, and then you follow the path. So in this case, at that point of time, we had only lung point. We did not have Synapse with us. Now we have both of them. So both of them perform pretty well. And this is how it is. So it gives us the path. So this is going into the RB1, posterior sub, inferior subsegment. And then this is where the lesion is there. So here there is an airway path. So this is how you do the path. And then cone beam CT is for seeing the nodule. Archimedes is for extra bronchial path, which we won't discuss today. Now, once we know the path, how do we reach there? Again, Dr. Loveleen, will the choice of bronchoscope make a difference?
Yes, we have basically 2 types of bronchoscope. One is thin bronchoscope, that is less than 4 mm, and ultra thin, which are less than 3.5 mm. This ultra thin gives better diagnostic yield, maybe around 70% compared to the thin, which gives around 60%. But ultra thin, the working channel is around 1.7 mm, which is slightly on the lower side. So, but for that, I think cryo will work better in these cases. But yes, ultra thin will definitely give a better sampling, better diagnostic yield than the thin bronchoscope.
I think the message which Dr. Loveleen is telling is, unlike a normal bronchoscopy, if you want to do a peripheral lesion, you should use a thin scope or an ultra thin scope. So thin is around 4 mm, ultra thin is around 3 mm. Only then you will be able to reach till as close to the nodule as possible. Your aim is to go as close to the nodule as possible, so that you will be more accurate in seeing or visualizing the lesion. So that is what Dr. Loveleen has said. So Dr. Vipul, can you just very briefly talk about augmented fluoroscopy?
So what is augmented fluoroscopy? It is nothing but the overlay of the outline of the 3D image of the lesion onto the 2D fluoroscopy which we'll be using. So for example, in cases where the lesion is very small, or there is a ground glass lesion, or if the lesion is say behind the cardiac borders or behind the diaphragm where we can't see the lesion on the fluoroscopy, so we have these two different systems. One is your lung vision system, or the other is the CBCT system, in which in a lung vision system there is a the CT which is pre-procedure. You can just mark the lesion on the pre-procedure CT, and then this lesion will be showed on your fluoroscopy when you do a fluoroscope as a 3D image. So this will help us to guide towards the lesion. The one which we have at our place is the CBCT system, in which we do a live CT spin before the procedure. We mark the lesion, and this lesion is which will be seen on a normal fluoroscopy. So this helps us in guiding the bronchoscope. It also helps in confirming the tool-in lesion using the augmented fluoro as well as the multidimensional fluoro.
So this was the case, index case. So normal fluoro, this was not seen only. So, but augmented fluoro, if you have access, I'm sure many centers may not have access, but you should at least know that this technology is there. So this is how it is. The overlay will be seen on the conventional fluoroscopy, and then you are more confident when your scope reaches there. If the lesion is large, then you won't need an augmented fluoro. It is seen anyway on the fluoroscopy. So that is what is fluoroscopy. Only when fluoroscopically it is not seen, augmented fluoro will help you. If it's a larger lesion, then even a normal fluoro will suffice. Now, Dr. Samir, so once you have reached the nodule, very, very briefly about how to do radial EBUS, just for everyone, because this is not about radial EBUS, but just to finish it.
Yes, so basically radial EBUS is a probe. The average size would be anywhere from Olympus is 1.8 mm. So unlike a conventional EBUS, you can use your normal bronchoscope. You go inside the bronchial tree. You should have an understanding of the CT scan, try to reach the target lesion, use a fluoroscope to reach the target lesion, go inside with a radial EBUS through your conventional bronchoscope. You don't need a dedicated EBUS scope for this. Your radial EBUS, once it goes into target lesion, it will tell you whether you're inside the lesion or adjacent to the lesion, which we can say as a concentric or an eccentric sign. Then you come out with your radial EBUS and go inside with your biopsy tool, which can either be forceps biopsy or a cry biopsy tool. Disadvantage is it is not real time, but the advantage is obviously we can go for peripheral lesion, and it has shown to be very much useful with addition to all the navigation tools.
Yes. So radial EBUS, I would say, is the backbone. So if any pulmonologist wants to do a sampling of a nodule, at this point of time, you should have a thin bronchoscope. You should have a radial EBUS. I think all of us agree with that point. Now in India, we have Olympus and Fuji. Both of them have radial EBUS systems. These are the specifications of the Olympus probes. This is the guide sheet kit which Samir was talking about. And this is the brief procedure. So this goes through the working channel of the bronchoscope. And then you see a 360-degree view. So this is an eccentric, which Samir was talking about. So then we went into the adjacent subsegment. And then now we have a concentric view. Our aim is to try to get a concentric image. Because if you get a concentric image, then your yield is much higher. So concentric, eccentric, adjacent, that is what it is. So because of lack of time, we will ask one important question to Dr. Loveleen. What do you feel is the most important disadvantage of radial EBUS?
Most important disadvantage is basically that whenever we are taking the biopsy, we are blind because we'll just keep. There is a more important disadvantage.
So unlike linear EBUS, it is not real-time sampling. And in fact, that is where most of the advances are trying to happen, how to make it real time. So you won't have real time sampling. So that is, which again means you won't have the tool in lesion confirmation. For example, if you're doing EBUS, you can see needle in the node. So you have a tool in lesion confirmation. If Dr. Nikhil is doing CT guided biopsy, he can see the needle in the nodule. Correct? So that gives the highest level of confidence that you are in the target, which unfortunately is not there with the radial EBUS. So now I will again ask Dr. Vipul or Dr. Samir. So how can you have a tool in lesion confirmation on while doing bronchoscopy?
So to get a tool in lesion confirmation, a real-time tool in confirmation lesion, we can use a CBCT. So what can happen is we can just put a radial probe, or we can localize the lesion, then put a cryo probe, and real-time get a second CBCT spin and confirm that the tool is in the lesion, and we'll be more confident in taking a biopsy. That is
What
one way
about
of.
centers where there is no CBCT?
For centers where there is no CBCT, if the lesion is visible on fluoroscopy, then definitely we can do a multidimensional fluoro where we can rotate the gantry to 30 degrees, both left and right, see that the tool is within the lesion on the fluoroscope, and then we can perhaps get a biopsy.
Correct. So I think there are two things: fluoroscopy and cone beam CT. This is the two tools for tool in lesion. So the third gadget which I feel is important is a fluoroscope. For all the pulmonologists, thin bronchoscope, radial EBUS, and a fluoroscope. So once you do radial EBUS, mark the lesion on the fluoro, then you put a forceps or a cryoprobe, and then you again recheck. So fluoroscopy is the simplest way to get a two-dimensional tool in lesion. But if you have access, then you can have a three-dimensional tool in lesion on a cone beam CT. So this was the index case, as Vipul was telling, because we have access. I don't tell that everybody has to do CBCT. So the ground glass lesion with the probe inside, we did a CBCT spin. And then you can see in all planes that we are in the ground glass nodule. So that is the most accurate way to confirm. Dr. Nikhil thinks like I do it every day in the same way. So what is the big thing? But for a bronchoscopist, this is something which increases the level of confidence. Now, coming back to the last part of it is sampling the nodule. So Dr. Loveleen, once you have reached, what all samples will you take?
So we can do the brush biopsy. It can be taken before the biopsy or after the biopsies. Usually we don't take it much, but these are the samples we can take it. Another is your bronchoalveolar lavage. You can go ahead with it to rule out any infectious pathology in these cases. Third one is you can take the normal biopsies with the normal forceps biopsies you can take. Fourth one is your cryo biopsies with the small cryo probes, or the larger one you can take these biopsies. And last one is your TBNA, needle aspiration also you can done from these lesions to assess the lesions.
Correct. So there's the 5 things, correct? Brush, ball, forceps, cryo, peripheral TBNA. This is not EBUS TBNA, it's called peripheral TBNA, PTBNA. Now we have the new needle in India. Outside India, Samir knows a lot of needles are there. But in India, we have only one Olympus Periview Flex needle. This is for peripheral TBNA. Now, for all of you who don't know Samir is also called as the cool dude or cryo man of bronchoscopy. So, when do you choose forceps over cryo or cryo over forceps?
Yes, so I think so. One major advantage of cryo over forceps, other than the size and architecture, is that it can catch hold of any adjacent lesion. When you activate a cryo probe, it can get you a biopsy from the adjacent lesion. So as we saw in our radial EBUS imaging, if it is a eccentric or an adjacent lesion, this is where a forceps might not give you the right sample. So this is where you will go ahead with the cryo biopsy, but you need to be prepared for complications of bleeding, which are low for peripheral lesion but higher than forceps biopsy.
Absolutely correct. So if you have a adjacent or eccentric lesion, you choose cryobiopsy or peripheral TBNA. But if you do cryobiopsy, be prepared to handle the bleed. Bang on. Now, Dr. Shilpi madam, so how comfortable are you to coming by the bronch side and giving us rapid onset evaluation? Will
Yes,
it help us increase the yield?
definitely it will increase. As Dr. Samir rightly said, we treat this procedure like a frozen. We follow the frozen rules in the when we're doing rows. Because it's a previous, and most of the time these EBUS cases you are referred by the oncologist. So oncologist want more tissue and more tests. So in the triage, we give the real time feedback to you. When in the rapid time, I will say that it is a tuberculosis. Then we can sample the microbiology, and if there is clear-cut squamous cell carcinoma or adenocarcinoma, so then we can skip the IHC sometimes and directly go to the molecular testing. So it helps in the triage and how we increase the yield, diagnostic yield to the our oncology colleague friends.
Excellent, madam. So very brilliantly said. 2 advantages. One, it will increase the yield. There is data also now, meta-analysis also. For example, if you do a biopsy, if the pathologist says it is not representative, you might do a different site. And and get a different tissue. So that is one thing. Second is triaging the sample. If on the first biopsy, madam tells me it's a granuloma, I will do a BAL. If madam tells me it's a malignancy, I will take more tissue for molecular markers. Very good, very correct, madam. And then
And
what do you expect
sometimes you have
from?
to change route also. You have to change route also. Yes,
Yes.
bronchial contamination is very much there. So you have to
Yes.
go from esophagus route to get the
Yes.
more yield.
So now, what do you expect from us? How big a sample is enough for you?
So
Because there's
first and
always a conflict
foremost,
between pulmonologist and pathologist.
yes.
That we get good tissue, you
So
will tell microscopic tissue.
So first and foremost is the representative sufficient tissue for the diagnostic for all tests. And the second thing is you should teach your technicians or staff how to handle the care of tissue to avoid these crushing artifact and the fragmentation this time. Then some clinical information based is a must, and the tissue in proper fixative, because sometime we get sample in the evening also, so there will be proper fixative and clinical details definitely.
Yeah, thank you so much, madam. Now, before we wind up, I think this question, first question, I have already answered. So, Dr. Samir, what is new as far as bronchoscopic modalities are concerned for peripheral nodule sampling?
So I will tell you a few things. Don't get intimidated. A lot of these things are new. They sound very complicated. We are very much adept with the tools that we have discussed till now. But there are some new tools. There is something called as an iris scope, which is 1.3 camera. We can go to the most peripheral part of the lung, and instead of relying on the CT image, you can get a direct image of what you're looking at inside the lung for a peripheral lesion and take a biopsy. There is something called as robotic bronchoscopy, which will help in minimizing the errors, ensuring that you are inside the tool. And if the patient is breathing, whatever divergence is there, that will be completely nullified. There is something called as ablation, wherein now the bronchoscopy will be used not only for diagnosis, but you go and ablate the lesion then and there. And last, there is something called as fiducial markers, which can be put through bronchoscopy so that your surgeon knows where he needs to do an excision. So you can listen to this and forget about this.
So, this is a lot exciting. I think in the next few years, we will have all of these things. Dr. Samir, you should get them to our country.
You will have it for sure, Dr. Nagarjuna.
Now, Vipul, again, very, very brief answer, please. What is the role of artificial intelligence? I think no webinar is complete without a mention of AI. Only 30 seconds for you.
Yeah,
Dr.
true that. So basically, the role of AI is first of all detection of nodules, be it X-ray or be it CT. Nodules which are very small on X-ray can be picked up on AI, and those are nodules which we can subsequently do a CT scan and find a early lesion. So detection is one thing. Second thing is lesion characterization. So AI can characterize the size, the margin, the texture, whether it's a solid, subsolid, ground glass, much more better than what we could do. Third thing is it can also help in risk prediction. So there are AI models which can risk predict nodules, which can track nodule growth over time, so that we know which nodule accurately, we know the volume of increase that has happened, the change in texture that has happened sometimes, which will help us guide or make a decision whether to biopsy or not. And the most important thing in our country where there is no screening is it's like tracking of these patients, making sure that they come on time for subsequent scanning and then biopsy and detecting disease at an earlier stage. So AI, I feel, has a huge role in nodule detection and nodule management, and it is something which we are actively incorporating at our center.
Yeah, there is some issue, some signal problem. So at our center, we started Cure AI very recently for nodule detection. Dr. Shilpi, madam, AI in rose and pathology.
Yes, sir. Many centers there is a lack of cytotechnologist, also cytopathologists also. So there you can use telepathology and AI. Like for AI, we have good quality of smears. It is the first requisite, and we have a lot of data. Now in present time, our histopathology is also transforming into digital pathology because of whole slide imaging. So in near future we can use AI. In I think I at LinkedIn, one of your from your center also. I think you are using Rose for some artificial intelligence. You have.
only for, we had used it only for a couple of cases, madam. But
Okay.
AI we are using for X-ray and CT, more for
Okay.
X-ray and CT than for the lung
Because
nodule.
there are many gray, they are like bronchial contaminations of cells, and then these epithelial cells. Epithelial cell, I think directly AI image can give it correct. But there are many differential diagnosis, difficult cases also where you can small cell carcinoma where you can not correctly say whether it is malignant or lymphoid tissue or these. So in near future when we have more data, I think, and more
That is
learning,
the future. So
and
as you had
and
said,
learning, and some apps also. I think deep learning app or some nerve module app. These are coming in future. I have searched this.
yes, thank you so much, madam. So Dr. Samir has shown us the glimpse of the future of bronchoscopy. Vipul has shown us the glimpse of AI in radiology. And Dr. Shilpa madam also is now talking about AI in pathology. So we have also taken up a lot of questions which the audience have posted as we had discussed along. So we are exactly at 9:30. And before we wind up, I'm sure we are happy that we had a wonderful discussion starting from detection, risk stratification on radiology, clinical prediction, bronchoscopy versus CT guided biopsy, where I think we have had a pact. Radiologists and pulmonologists have agreed on which nodule will go for pathology and which to radiology and which to pulmonology. Then the steps of bronchoscopic sampling. I think this is the most important thing. And Shilpa madam has also given insights into a pathologist as to how they can help us. So before we wind up, I will request all the panelists to give a one-liner take-home message for the audience. So Dr. Samir.
Yeah, so I think so. Peripheral lesion biopsy is a major part of our intervention pulmonology practice, depending on whether you are attached to an oncology center or you are using the radial EBS frequently. It is not a very difficult tool. Once you get the tool in your hand, I think so. Learning curve is around 50 procedures is what is said. So peripheral lesions in India need to be taken more seriously. Dr. Nagarjuna has conducted a lot of programs and is running a program on nodules. And I think so a lot of centers can come up with similar practice.
Yes. So next, Dr. Loveleen bhai, your message
I
to the
think
audience.
we are getting now more cases of peripheral pulmonary nodules, and we definitely we can't avoid this topic right now, because as Dr. Nagarjuna earlier in his talk already said, that we are getting more of CT scans now, more of screening CT scans for some other purposes and health checkups. And he has shown one of the cases also in which they have done CT scan for health checkup. So we will definitely this is going to be increase in our practice. So we need to be prepared for that. We need to know about what are our basics, and accordingly we need to choose our tool accurately for diagnosing these cases.
So Dr. Samir has said that we should start learning Redilibus, 50 procedures, and then you will probably increase your diagnostic curve. Dr. Loveleen has said that there's no going away. We have to learn the approach, the right way to sampling or deciding whether or not to sample a nodule. Dr. Nikhil, from a radiologist perspective, what is your take-home message to the audience?
We should not ignore small nodules or small GGOs.
Absolutely. I think it's a huge claps. Many times we ignore them. So never ignore a nodule. Always write down and ask them to come for follow-up. A small nodule, I have shown two cases where we had it's small thing ignored and then it became big. So never ignore a nodule just because it is small. You may not biopsy, but you have to follow it up. Correct. Dr. Vipul, your message to the audience.
I will second what Dr. Nikhil and Dr. Nagarjuna just said. Detect nodules, identify them, risk stratify them, and most importantly, sequentially follow them. Even if you don't biopsy, sequentially follow them. And when the time comes, follow up 3 years or 5 years as maybe the texture of the nodule, and then come to a conclusion.
Yeah, so what Vipul says, whenever nodule is there, follow the entire step from
Yes.
detection, distratification till you get a diagnosis. The diagnosis is not always biopsy. Lack
Yes.
of growth for 2 years also is diagnosis.
Yes.
Dr. Shilpi madam, what is your take-home message?
Multidisciplinary approach, make a team of oncologists, pulmonologists, radiologists, and including histopathologists in your team. And with the help of histopathologist or pathologist with the rows, you can correctly diagnose and increase your diagnostic yield of your patients.
Madam has stressed upon the fact that the nodule MDD. I think we should have nodule MDDs. We have ILD MDD. We
Yes.
have tumor board. We should have a
Tumor board.
nodule MDD to determine the exact plan for the person, and pathologist can make our lives easier, much easier. I think that is definitely, madam. So I will again thank every one of you for spending your time, 1.5 hours, and educating all the people across the country. And you'll also take, again, I will want to thank the CCI for providing this platform where we all have spoken. So thank you so much, audience, also for logging in and listening to all of us. Thank you once again. Bye.
Yeah, thank you, everyone.
Thank you.
Bye.